An 81-year-old female presented to her primary physician with a single episode of right upper quadrant pain. The pain was sudden in onset, lasting approximately 30 minutes, resolving quickly and spontaneously. She had no prior episodes in the past, and her symptoms were associated with mild nausea. A CT scan obtained 9 months prior had incidentally noted cholelithiasis with minimal sludge in the common bile duct. Thus, biliary pain related to symptomatic cholelithiasis was suspected. Transabdominal ultrasound was ordered for further evaluation, again revealing cholelithiasis and focal sludge in the common bile duct, with a common bile duct diameter of 8 millimeters. The patient was referred to our pancreatico-biliary clinic for further evaluation. An MRCP was ordered to further evaluate these findings. This cholangiogram image obtained from the MRI reveals numerous filling defects within the gallbladder lumen, consistent with cholelithiasis. 2 additional filling defects were seen outside of the gallbladder lumen, one at the level of the cystic duct, and another at the confluence of the left and right intrahepatic ducts. Both of these lesions were felt to represent stones or sludge. Due to the MRCP findings, an ERCP was planned for further evaluation and attempts at therapy. Cholangiogram images obtained from the procedure demonstrate numerous filling defects within the gallbladder lumen, seen on the left side of the image. Additionally, one filling defect was noted in the proximal common hepatic duct near the confluence of the left and right intrahepatic ducts. A second filling defect, not seen on this image, was noted in the mid-common bile duct. Biliary sludge was extracted from the bile duct. However, the proximal common hepatic duct filling defect could not be cleared despite numerous attempts, and therefore a plastic biliary stent was placed. 3 days after the procedure, the patient presented to the emergency room with severe right upper quadrant pain and mild leukocytosis. She was afebrile, and no pericholecystic fluid or gallbladder wall thickening was seen on right upper quadrant ultrasound. A CT scan was obtained demonstrating pneumobilia attributable to the recent ERCP. However, given concerns for cystic duct stone on prior MRCP and acute cholecystitis as her presentation, the decision was made to pursue laparoscopic cholecystectomy. 49 days after the initial ERCP, another procedure was undertaken for biliary stent removal and another cholangiogram. Again seen is the filling defect at the proximal common hepatic duct, which after numerous attempts failed to be extracted. A decision was made at this time to pursue digital cholangioscopy for further evaluation. Upon inserting the cholangioscope into the bile duct and advancing it proximally, an obvious neoplastic lesion was encountered. The lesion was polypoid, friable, and surrounded by relatively normal-appearing bile duct epithelium. Despite numerous attempts, the cholangioscope could not be advanced proximally to the lesion. In an effort to obtain tissue, numerous biopsies with intraductal biopsy forceps were obtained. There was a small amount of bleeding, however this resolved. Histopathologic examination showed papillary mucosa lined by benign cuboidal cells, without any evidence of dysplasia or malignancy. The patient's case was presented at our multidisciplinary pancreatico-biliary tumor conference. The consensus was that the lesion likely represented an intraductal papillary malignancy. Discussion was undertaken, and it was felt that the likelihood of sampling error was high. This was based on the presumption that polypoid neoplasia can harbor hidden cancer or degenerate later into cancer. Further, though the sensitivity of intraductal biopsies for malignant biliary strictures ranges from 60 to 75%, the sensitivity as it relates to polypoid neoplastic lesions of the bile duct is unknown. As a result of this discussion, decision was made to pursue surgical resection to to which the patient was agreeable. Shortly thereafter, the patient underwent an extrahepatic bile duct resection with a Roux-en-Y biliary reconstruction. This low-powered histopathologic slide represents the hepatic duct lumen with an intraductal papillary growth. On high power, the intraductal tumor is noted, along with the focal area of invasion, as identified by the solid black arrow. The final histologic diagnosis was invasive intraductal papillary carcinoma involving the left hepatic bile duct. The tumor was staged at P-T1. A consultation with an oncologist was obtained. However, given the patient's age, her other comorbid conditions, and sparse data demonstrating any benefit, the patient elected to forego any adjuvant chemotherapy. In conclusion, papillary neoplasia of the bile duct can masquerade as gallstone disease on various imaging modalities and may only be discernible with direct visualization or tissue sampling. In our case, digital cholangiopancreatography provided sufficient supporting evidence of a biliary malignancy, prompting surgical resection without a confirmatory preoperative tissue diagnosis.